Hello, hello. Welcome to the Polestar Pilates Hour. We're going to have, we have about 600 people again that have signed up and probably close to about 200 that are attending live. So welcome, welcome. We're going to be doing a case study today on chronic pelvic pain. Before we do that, I had so many questions from last webinar that are pertinent to today's webinar as well, talking about the pelvic floor, and I pulled out a number of those questions that I thought I would take the opportunity to answer. I see that I have somebody from Argentina and Israel. Fantastic. Emily Bondi from our local North Carolina. Athena from Greece. Very good. Cool. Thank you, everybody. It makes a big difference, I think, when we see how globally we are reaching out and people that are interested and friends of ours. We had the Polestar experience Saturday, and that was also great. We had over 100 people attending it throughout the whole day, and we got to do something looking at the future. So it was really good working with groups and breaking them up. And I think one of the best things was getting to meet people from different parts of the world and to be able to establish some new relationships, some new bonds. So let me go into a couple questions. I pulled out about 7, 8 questions that I thought would be pertinent to the discussion today, and then we'll jump right into the interactive case study. Since we've already done sort of the science of what we're talking about with the pelvic floor, now we're going to apply it today, where a couple weeks ago we did one on the shoulder impingement, and we spent about 20 minutes actually reviewing shoulder impingement before going into the case. So I hope that that helps and that you can appreciate that. So one of the questions was, did the women with prolapse who showed positive displacement, was she currently experiencing incontinence, or was it something she experienced previously? She had shown that she was still having incontinence, stress incontinence. So if she coughed or jumped or moved too quick or had a full bladder, that if she moved, that she would have some incontinence. So that was, again, I think the point I wanted to make is that there are women that had problems, right? They had challenges with incontinence, but when we measured their volitional contraction, I think that's really the key here is us understanding, is there a direct relationship between the pubococcygeus lift, the pelvic floor lift, and the urethral sphincter, or in other cases, other pathologies like prolapse, or like we're going to see as a chronically hypertonic pelvic floor with pain. Next question, can we look at pelvic floor as other muscles that if it keeps on practice lifting it, it will get better in the time, and if these same teachers x-ray taken again in the future, we can compare. So we were actually using real-time ultrasound, and the question is, it's a muscle like any muscle, so yes, all tissue responds to adaptation. So the more we use it, the stronger it gets. Most of the time, that's a good thing. I would imagine it's a good thing. However, I just want to bring up the point that a lot of times the pathologies that we see in the pelvic floor are related to a hypertonic, meaning that they're held too much. There's too much stress, so there's not enough movement in it. So then teaching that person that still might have a stress incontinence to do a Kegel or to do a pelvic floor lift might not be the most appropriate exercise, might actually feed into the hypertonicity that they're dealing with already. So just a heads up there. Next question, does the study change the way you cue contracting the abdominals and to avoid increasing intra-abdominal pressure causing descent to the pelvic floor? And the answer to that is definitely yes. So again, if you've worked with me in the past, one of the things I try to do is to create the proper alignment with the proper load. So it doesn't mean that I want less intra-abdominal pressure, but I want the appropriate intra-abdominal pressure for the anticipated activity. So if I'm carrying 2 jugs of milk, I have to have a higher intra-abdominal pressure than if I carry 1 jug of milk, or 1 jug of milk on one side. So it's going to vary based on the activity that we participate in. I think that's really important point is that we want the appropriate amount of stiffness for the anticipated load. So somebody who always holds their stiffness or always contracting the powerhouse, always holding the abdominal in, actually do not necessarily have better intra-abdominal pressure control. I'll say that again. Somebody who has the strength, or not the strength, but somebody who is holding or has contractures of these abdominal walls, the diaphragm, and pelvic floor, do not necessarily have more intra-abdominal pressure capacity. As a matter of fact, it actually would be less. And so it is the dynamic nature of these muscles working together that are responding in the healthy individual to their anticipatory load, right? So what you expect. So when a child learns, they are basically able to take an event, a task, and their body starts learning what is appropriate. And they might anticipate too much or too little, and they fall down. We're the same way when we come back from injuries or pathologies or childbirth. Great question. Is it possible that a weaker pelvic floor go down rather than lift up as it cannot properly contract? And that is possible too, right? So if the pelvic floor, the pubococcygeus complex, is weak, then it might not be able to sustain the pressure that is anticipated. And so for that reason, it would drop down. But I want you to realize that I believe it should be in response to breath during a sustained load. So if I'm carrying those 2 gallons of milk and I am walking from the store with a gallon of milk in each hand, I can't hold still for the full 15 minutes walking. I have to breathe. So as I inhale with that intra-abdominal pressure to hold the 2 gallons of milk, my diaphragm is going to descend, which means that my abdominal wall and my pelvic floor have to expand, maybe eccentrically, to be able to keep the intra-abdominal pressure constant. And when I exhale, I would expect to have a reflexive or elastic movement of the pelvic floor and the abdominal wall to keep the intra-abdominal pressure constant for the weight of the milk. The weight of the milk has not changed. So the intra-abdominal pressure stays the same, but breath will cause the displacement of the abdominal wall or the pelvic floor in a subconscious effort to keep the proper intra-abdominal pressure. All right. Hope that helps. Were you able to see if the participants had a hypertonic pelvic floor? Yes, that we showed that in the video. You could see the pelvic floor when it domes up in the middle, even when it was pushed down, if you saw it domed up, we think that is depicting hypertonicity. And there was a question, what is the best practice after giving birth? And that one is, I don't know that I can give you that advice. I just think that the best practice is Pilates practice. You know, we practice breathing, whole body movement, articulation of the spine. And because if we can do more work in Pilates in the vertical orientation, we're going to have more work for the pelvic floor. The more we do horizontal, we're going to have less work for the pelvic floor. So ideally, my thought would be, you know, great Pilates and make sure that you're incorporating some vertical work with it, or walking, or things like potentially, you know, 6 months out to start doing some, you know, jumping on a trampoline or a little bit of jump rope or something. Can you clarify again how to increase our chances of lifting the pelvic floor during a Pilates class? So again, we've done this with a couple of the exercises. I can just tell you the one that we have seen consistently is the washerwoman or hamstring one, where you're standing in front of the chair. And in particularly, if you go down into kneeling in front of the chair, keeping the femurs perfectly vertical, hands on the pedal, and articulate the spine down in front of the seat of the chair. And by doing that and coming back up full range, keeping the femurs vertical, we found with the ultrasound that everybody we've tested so far has actually had a natural pelvic floor contraction. We also have seen that sit to stand, that we have about a 90% of people that have spontaneous lifting the pelvic floor just doing a sit to stand from a chair. Question, is there any sensation we should be aware of when the pelvic floor is lifted? Yes, there is. And so just like it's proprioception, And I think that's what's so interesting to me about this study, and we need to know more. But why did people feel or think they were feeling the pelvic floor lifting up when it was actually going down? And there were some that just didn't feel anything, and the ultrasound showed that there was nothing. So it could be that they just are not aware of that area or aware of how to contract that muscle. And that's not uncommon. So a lot of times using the ultrasound is a very nice way to re-educate somebody. They can actually see it and identify what they feel with what they see. And we've done the same thing with the transverse abdominis and the same thing with the multifidi. Not to create a voluntary contraction of it, but just to sort of see and feel how subtle it is. Paul Hodges and Richardson in their original study said that it's probably somewhere around 20 to 30% of a max voluntary contraction. So it's very subconscious, subthreshold contraction in the normal adults dealing with maintenance of intra-abdominal pressure. So most of the time, we're just not even aware of it. All right, I think that's it for there. I'm going to jump in. Let's get going on this interactive case study. You guys got your phones ready. We will be using Mentimeter today. This is a case that I had about 3 years ago, and it really is dear to my heart. She was a student at the university and was just having to drop out semester after semester because she would keep enrolling, trying to finish up her last year, and she just couldn't tolerate sitting. She even got to the point where she would lay in the aisle of the auditorium. She'd bring a pillow so that she could at least listen to the lecture, but she did not tolerate sitting due to the pelvic floor pain that she was having. So biggest complaint, couldn't sit longer than like 10 minutes. She's unable to use tampons. Nothing could be inserted. Pelvic floor exams from the gynecologist were extremely painful for her, even with lubricant. She has a boyfriend, but they're not sexually active. She can't tolerate any kind of engagement in the pelvic floor. Parents are very supportive. Father is a physician. Didn't seem like there were a whole lot of factors that could say there was no accident or history that we could tell of any kind of insult or rape or assault. The symptoms have not improved with physical therapy. She had been taking muscle relaxers and even did a month treatment with gabapentin with no significant relief, and she got off of those medications. So this is our client, Sally, and that's obviously not her name, but we'll use Sally for the sake of the case. So here we are dealing with a young adult, female adult, with severe pain that is compromising the quality of her life in many, many facets. When she does have her period, it is enhanced by 15, 20% the pain, and probably just because of the attention and the cramping and other things that are associated with the cycle. But the worst time is about the week before, with premenstrual cramps and the pelvic floor pain that were just making her life absolutely miserable. All right. So let's take a look and see how she presented. So as I always ask my patients or clients, what do you believe you're not able to do that you believe you should be able to do? And so she's like, look, I can't sit longer than 15 minutes in class without severe pelvic pain. I'm having to drop out of school term after term. And the other big one is that she could not be sexually active with her partner as a young adult. And so I asked her, what do you believe prevents you from participating in these activities? And she really, because she had been through so many medical exams and so many tests and ultrasounds and pelvic floor exams, all seeming to make her worse, she just said, it's just severe pelvic pain. It feels like a continual vice combined with a knife in her pelvis, quote unquote. So it sort of puts us into a position now. She's coming because she has exhausted all of the other types of interventions, and she's looking for some help. And she comes to us because she knows that we do Pilates, and she heard that Pilates had helped people with pelvic pain, incontinence, and other problems. So let's get your phones ready. And we're going to get onto menti.com, and the code is 7441548. And let's go to our first question. So before assessment and based on subjective information up to this point, what would you hypothesize Sally needs from us first and foremost? Like, how do we address something for her immediately? All right, so let's take a minute and answer that question. Let's see what you guys say. Let's see what we're looking at here. All right, I think you guys are right on the money. Of course, the stronger pain medication is out of our practice scope, so I'm glad to see nobody put that in there. The other are options that we often talk about, and so we'll see what we think as I give you a little more information. But I agree with the majority. I think I don't always agree with the majority, but I agree with the majority on this one, that if we could get her in some, think of all the toys that we have in our Pilates studios. Couldn't we come up with something that could potentially keep the pressure off of the pelvic floor? That was one of the first things that I wanted to be able to do for her. So yeah, modifying that. And Sarah, you bring up an incredibly good point, empathy. This poor girl is so distressed and so distraught that, empathy and kindness could go a long way. She's been sort of she felt like a little bit of being in a meat market, having to have, 22-year-old having her pelvic floor examined by, I think by the time I met her, she had already had 6 or 7 pelvic floor exams from different doctors and therapists. And, her father's a physician, making sure she gets the right care, which might be part of the problem too, is putting too much attention on it. So let's continue on. Very, very good choice, everybody. I'm right with you on that. All right. So with that, what activities will Sally need to be able to do to perform successfully? To participate in her daily activities, from what she said. So again, I just want to make sure that we understand. We ask a question, and then we have to think about what her answer was to us. What's the most important thing to her? So let's get those going and get them in. Let's get up over 50, 60 comments. And while you're doing that, Betsy, good to see you. The great question. Did her symptoms come on suddenly or gradually over time? And it really was gradual. And I'll tell you, is over about a 2-year period that she was having, actually, and I'll give you some more information in the next slide, but it will answer that question for you, Betsy. And again, that's why we sort of start our mind thinking, and it should lead us to wanting to know, more questions, right? We want to have more questions and more answers. So I think because of her particular response to me was those 3 areas, so you would be right in wanting to address all of those areas. You could see how, even if we can control some of the pain or control some of that symptoms that she's having, that she could start functioning, feeling like a normal college kid, going back to class. Not that I'm promoting premarital sex, but she has this relationship, and that as an adult, she should be able to participate in that relationship. And then just something as simple as feminine hygiene is a nightmare for her, the hypersensitivity down there. All right. Very good. Let's go to our next slide and give you some more information. So physical presentation. Sally finds herself often holding her breath. She's very slender and has little to no rib cage movement when she's resting. So when she's sitting there, she's almost like she's holding herself. She breathes with accessory breathing, slender little thing. While observing her sitting, I observed that there's no diaphragmatic breathing. And though she's very slender, she does come from a history of eating disorders. So Betsy, it was great for you to ask what else was going on there. But she had been treated for eating disorders and anxiety disorders prior to coming in, as we started talking more about her condition and how long this has been going on. So the history was about 2 years, and it sort of started manifesting after the treatments for the eating disorders. Okay, so she'd gone through, let's say, I think she was like 19 when she was diagnosed with bulimia. And she then was getting treated, went to a rehab center for it. And it was following the rehabilitation that she started having more like fibromyalgia-like symptoms on her body, but most of it concentrated on the pelvic floor. And with this boyfriend that she's with now, she's never been sexually active with him because it's too painful. So it's not even like she had sex and then had pain. She hasn't. And she loves him, and they want to be together, and they live in the same apartment, but they are not sexually active. So some probably more information than most people want to share, but what we're dealing with, this is the kind of thing we need to know. Medical's clear from all the medical tests, like there was no nerve damage. There was no other types of pelvic floor dysfunctions or things that were going on with the uterus, the cervical, the vaginal wall. All those things came back normal. John Mallins, you ask a very interesting question. So what do you think? If I told you that she had a hypermobility disorder, what would you think? Anybody familiar with that? I always forget the ERS, ERL. I always forget the acronym for it, but the laxity, tissue laxity. So she is one who has been suffering from the tissue laxity problem, or was diagnosed at least by an osteopath with that about a year or two when she started having the fibromyalgia like symptoms. Ehlers-Danlos, thank you, EDL, yeah. And so she was diagnosed with that diagnosis. Now, I personally, when I tested her, did not feel that she fell into that category. So, but funny enough, she was diagnosed with that by an osteopath about a year into her fibromyalgia symptoms. So you can tell she's sort of been a pincushion. She's been, treated by many, many doctors, and here we are now. So this is the insight that we have. I want to bring special attention to the fact that she's not breathing through her diaphragm, through her rib cage. The abdominal is tight as a drum, which also leads me to think, and I did not do a pelvic floor exam on her, but I had Pam Downey do a pelvic floor exam with her, that her pelvic floor was hypertonic, right? So it was not flaccid. It was in a spasm all the time. And remember, we talked about this last week. So Sarah brings this up, if she's not using her diaphragm to breathe, she sort of fell into that category of a couple of those Pilates teachers we saw. They didn't have any pelvic floor problems per se, but what we found was that their pelvic floor could not lift, and that their diaphragm was actively insufficient, and that their abdominal wall had contracture. So the oblique abdominis internus was fixed, was rigid. Like they had held it so long that there no longer wasn't a normal expansion, contraction of that muscle, which also meant that muscle's weak, right? It's not strong. So let's go to the next slide here. Great questions, guys. All right. So assessment time. We've got this information. We've made a couple observations. What do we have going on here? What do we want to assess from our Pilates standpoint, right? Looking at our Polestar assessment tools we've been talking about. What do we want to look at and see what's going on here? Now, I see a couple questions here on the eating disorder. What trigger identified the eating disorder? If we viewed EDs as a symptom rather than a cause, perhaps the same root psychological factor are contributing to both issues. We looked into this. I do believe that the eating disorder definitely fed into what she was dealing with. And I also feel that the amount of pressure that she perceived to be perfect from her parents was a big part of this. And I can share another story with you later of another client I had that I'll explain as another case, sort of a short case. But it definitely ties into this. There appears to be zero history of sexual abuse or even sexual activity, as far as we can tell. She claims that she has not had sex. She would like to have sex, but there you have it. So, what people have in their perception. When I share this other story with you, it might be really interesting and insightful as to what's going on with Sally. So let's see what you guys are saying. All right, so the majority of you looking at chest expansion, some squat, a little bit of goalpost. I looked at all of them. I felt I was curious to see, for somebody that was diagnosed as hypermobile, there was very little mobility. And then when I tested things like skin and joints, I didn't see the hypermobile thumb or the elbow or the knees or, super flexibility. She did come from a recreational dance, more like hip hop and jazz while she was in middle school and high school. And she also liked to run track when she was in her first year of high school, but hadn't really participated in those activities. She started having an eating disorder, probably late high school, that was discovered in her first year in college. And again, she went to rehab on her history. Seemed to do well with that and did not seem to have eating disorders when she was with me. She had pretty good habits and kept a log of what she ate, what she kept, that she was no longer purging or doing any of those activities. But it's like you think of one behavior and how it carries over into another behavior, maybe. All right, so chest expansion was my most interesting finding that I wanted to look at. So let's take a look at that. So we looked at chest expansion, and this is our chest expansion test. And she basically had less than an inch of movement in either direction. So typically when we do this test, what we want to see is about 2 inches of expansion of the lower rib cage out with an inhalation from a resting breath, and then about 1 to 1.5 inches of narrowing from the resting position. So if I put a tape measure around the lower rib cage, and what's called a tidal volume in breath. Tidal volume is the unconscious breath that we're all doing right now. So you bring in a little air, you bring out a little air. It's just the unconscious breath exchange that we have. So on the unconscious breath exchange out is sort of exhaling. I make that my starting point. And then I have her do a full inhalation, right? The band is around her chest, and I measure the new distance in a fully forced inhalation. And that should be over 2 inches in most people. And then I let her go back to that resting exhalation, and then I ask her to do a forced exhalation, and I should get upwards of 1 inch of narrowing. So a total excursion of about 3 inches with the average person, healthy person. I've seen it as much as 5. And in this case, it was less than 1 inch of combined excursion, which really means nothing was moving, right? The abdominal wall was very tight. When we looked at the squat was my second test that I wanted to look at. She was very difficult for her to go down into a squat, not because of range of motion, but because of pain. I thought that was very interesting as well. So, if you think of the mechanics, and we've talked about bone rhythms, for example, with squatting and being able to, see what kind of range. She didn't have any problem as far as her ankle dorsiflexion, being able to go down into a squat. It wasn't really there. She didn't have hip problems or knee problems. But what she felt was, if you think of the diamond of the pubococcygeus, from the pubic symphysis to the coccyx and the sit bones, that she felt like as she was squatting down that her pelvic floor was, quote, ripping apart. So you can imagine any stress that would be taking the diamond of the pelvic floor into a little bit of stretching or movement or load from the body coming down on it. And that was her complaint, that she had a lot of pain going into a deep squat, but did not feel that there was any structure like in her joints preventing her from going into the squat. And then at that point in time, I didn't even test her mermaid at that time, even though I put it on my list. And I just wanted to, I saw those two things and it gave me a lot of information. So based on what we talked about last week, these are things that started triggering to me. So a couple ideas, right? One is sympathetic nervous system, right? Or limbic mode. So when people are stressed, we release more cortisol. We have odd behaviors. We get less sleep. We don't get good healing sleep like we should at night, which I failed to mention that she did have a sleeping disorder based on this, since the eating disorder, that she would, wake up every couple hours, never felt like she got a really good night's sleep. Was at a certain point in time drinking a lot of black coffee, which is sort of uncommon for a young adult. Usually they like to have sweeter coffees. And so she stopped drinking coffee based on some coaching and things that she was trying to do to eat healthier. And she did have a very healthy diet. She would explain to me what she ate, or she was very smart and she could lie to me, but I trusted her, that she was doing that, right? So again, Anthea, your question, this was the primary thing with the squat, that she had the pain with, even the idea of the sit bones moving a little bit was painful for her. And that could also be affected by the hips flexing, the way the hamstrings come into the sit bones, the fascial connects the pubococcygeus to the sit bone, to the hamstring, to the adductor magnus. They're all interconnected, right? The obturator internus, externus, all were super, super, super hot. Okay, so let's see. I got a couple questions here before we go to the next slide. And these questions are really important. And I know there was a comment, and maybe some people think I will always get through the material, but I want this to be really interactive. And your questions are so important to understanding this case. And this is the only way that we can sort of move through the case. So I just want to make sure everybody knows I will get through all the material. So Kathleen Mayer says, when did she start school? And does she have other stressors that are contributing from school? She comes from a very wealthy family. Like I said, her father is a well-known physician and leads a very large medical group. I'm sure that they're financially stable. And she doesn't have to have an extra job. She doesn't have any extracurricular activities as it stands right now. So she, I think she has had a very strong Netflix account, and spent most of the time laying in bed because of the pain, and was not able to finish the last year of her college. That now she's in like the third year trying to finish the last semester of college. So, the stressors would probably be internally induced. And as I said, there was no history of abuse. And talking to the mother, the father, sister, she has a sister. Her sister came in. I had a chance to interview a sister. There just doesn't seem external, internal family. There doesn't. That doesn't mean that it didn't happen. It just hasn't come forward yet. I've had those cases as well. But as far as we could tell, no. Lisa Kelly, would it be appropriate to refer for additional meditation and guided imagery, relaxation, in addition to what we can do for her? Well, that is what I do. But yes, that's exactly what we were, I would take her through a meditation. But more importantly, we're thinking of this breath problem that she has, right? She's really challenged with breathing, and she's really challenged being in this sympathetic mode or limbic mode. So the anxiety's high. She is on an anti-anxiety med that was working for her, but didn't seem to be working for her now. She doesn't want to take it anymore. She says it makes her feel bad. She doesn't want to see a psychologist anymore. She's seen too many doctors. Doesn't want to go to a gynecologist. Doesn't want to go to somebody doing internal work right now. So she's desperate, anxious, wired pretty tight. Sarah's comment, trauma held in the body, perhaps so. There must have been trigger for eating disorder. That's my gut feeling, no pun intended, that there was something that had to trigger the eating disorder. Maybe it was her dancing in high school and middle school. We see that with a lot of our dancers. We see it with a lot of high school kids. Mom and dad are both slender. Her sister's slender. She's slender now as well, but she was gaining weight, or thought she was. So anyway, you see the idea that it's complex. And what I want to do is I want to try to make it simple, because we did find a resolve. We did have a really good outcome. And I want us to work through and sort of see, how did we arrive at this good outcome? Nicola, your question of osteoporosis is a great question, because this would lay the ground for, right? We know people with eating disorders and inactivity and not a lot of vertical activity in their early adulthood as women often have difficulties getting the bone density they'll need in the future, so that maybe 45, 50 years old, they're already showing signs of osteopenia or those kind of things. Great question. All right, let's go forward. Let's see what we got here. Get you guys involved on this. So we can hypothesize that Sally's missing mobility in which of the following areas? While you guys are doing that, I'll look at a few more questions that came up. Debbie, I always ask this question. This is a great comment, and people could learn from this. Is I always ask, what do you think is preventing you from doing this? And I felt that Sally was very immature in her ability to articulate, her feelings. It was always a very short answer. So like, when you ask your teenager, how was your day? Fine. What did you do today? Fine. What do you want to do tonight? Fine, kind of thing. And it was almost more of that kind of answer. And, that was a big challenge for us. And eventually it took about 3-4 months to build enough rapport that we could actually talk about those things. So I think that's really important. All right, see a couple of things. Melissa Zinkowski, I'm betting she had super tight adductors. The tightest muscle that I felt on her actually was obturator internus. And that was one nobody had tried to release, funny enough, even those that had done internal work thinking it was more vaginal, where instead the obturator internus was the one that gave her the most relief from a manual therapy standpoint. And the horizontal squats on the reformer, she could even do the squats supine without a problem. She couldn't do them standing up. So good idea to think of some modifications there. Let's see what you guys said. All right, so the answer is ding, 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 all of the above. So remember, we're looking at the intra-abdominal wall. We saw significant decrease in movement in the thorax. We saw a decrease in diaphragm activity. Abdominal wall did not displace, was over-recruited, did not seem to be moving much. And then, of course, we know the pelvic floor was hypertonic. So basically, by doing the ultrasound, we could see that the pelvic floor was raised. Not that you would have that, but you might have somebody related to it. And we realized that however we prioritize this, and we'll talk about the prioritization in a second, how do we get access to eventually be able to move the pelvic floor without pain? So that's a prioritization process. Let's go to the next slide. So which limitations will become your primary objective based on knowing that we need to get movement in all three of those areas? I've seen some of you really putting great emphasis on breathing. So that's a little hint there. And, Donna, she had flaccidity in her quads and hamstrings and calf and glutes. Surprisingly, they were just but not surprisingly, she had not been active for 2 years. So it was hard to differentiate, does she have really tight hamstrings, quads? No, they were sort of soft. But when you got close to coming up into the sit bones where the hamstrings attached, there was a lot of tension in there, a little bit more of the squeezing. There was pain around the greater trochanter, which would also make sense of just some of the rotators coming in there, and that they were causing, trying to hold or protect herself. And then there's an anonymous attendee that said trauma can present in later generations. So maybe trauma is the lineage, and it certainly could be. And I can tell you, even in my own family, knowing that 1 or 2 generations back, there was sexual violation trauma, there was physical abuse. And that doesn't surprise me at all. So let's see what you guys said. Very good. And that was exactly where we went. So we went after breathing. And, I went after breathing with two reasons. One, I wanted breath to move, but I also wanted breath to calm down the sympathetic nervous system, right? So that was the comment before of what I refer out for, meditation and mindfulness. And I like to think that a lot of us have been trained in both. I don't want to make that assumption, but it is a very nice companion to our Pilates teaching to be able to take somebody through a breath meditation or a direct or indirect meditation, different ways that we can go with cueing, non-cueing, imagery-based. There's so many different types, or even just to refer them to, a free app that they could use to be able to do meditation a couple times a day, which we did with her. I just recorded her meditations and her breath exercises, and I had her doing them every time she had to go to the bathroom. So if she had to go to the bathroom, which was also always a painful event, I forgot to mention that, always a little constipated, afraid to defecate. Urinating did not seem to be a problem. Continence did not seem to be a problem, but wiping was painful to her. So she had hypersensitivity to the pelvic floor as well, probably from the hypertonicity, right? And the focus on that area. So breath was our primary focus on that. I think everybody's in agreement, and you're right on the money, so it's good. A couple other comments. Anthea Bell, when you started her on breathing activities, did she struggle to allow her belly? There was no belly movement. I actually had to do myofascial release to the abdominal wall to even allow the diaphragm to start to descend. So it took us probably about 3 weeks to get her to even allow the belly to expand. And it wasn't all fascial restriction. A lot of it was psychological restriction too. It was like, I have to hold myself so I don't have more pain, and not realizing that the holding was what was causing pain. Sarah suggested her own body self-awareness has been a limitation too. No doubt. And remember, our goal in Pilates is to create a positive movement experience. That positive movement experience could also be a positive self-esteem experience. Using proper language, getting away from negative language, and even getting her to not use negative language about herself, or no self-deprecating comments, or focusing on all the things she can't do. We were trying to focus and journal on the things that she could do, which was very important. Ozgul said to give from Turkey. Hello, Ozgul. Good to have you here. To give massage to the vagus nerve through movement of the diaphragm. Yes. So again, that is part of the sympathetic parasympathetic system. So in the hypothalamus, the base of the brain, we need to get in there and give her some downtime from being in sympathetic mode. And so that's why breathing actually moves the vagus nerve, and the vagus nerve controls almost everything to do with digestion, and all of the gut functions that we have often are from the vagus nerve. The heart also is controlled both by the sympathetic and parasympathetic. So if we can get her into parasympathetic mode through relaxation and breathing techniques, we could make a significant change. And remember, what happens, before we go to the next slide, what happens if she starts diaphragmatically breathing to the pelvic floor based on our experience? And while you're answering that question, Irena, I wouldn't say it was weakness, but she was weak all over, right? So she was deconditioned is the term that I would use for her. And so, there's no way her back could have sustained a backpack. Her boyfriend carried her purse for her. So, it was like clothing sometimes felt too heavy for her. So yeah, she was very deconditioned. And I wouldn't say it was because the back was weak, but I would say that her back is weak in this situation at this stage. All right. So you're right. So what happens when you breathe? The diaphragm descends. From our research, we find that the pelvic floor is going to accompany that descent. So if she is in a relaxed position and she takes in a deep breath and has a thoracic expansion and diaphragm descends, the viscera has to go somewhere, and it actually is going to push on the pelvic floor. So without us bringing attention to the pelvic floor, we just focused on breath for the first 3-4 weeks and putting her on a program that every time she go to the bathroom 5-10 times a day, that she was doing her breath meditation that took maybe 3 to 5 minutes, right? Something very simple that she could repeat over and over again, doing breathing exercises, right? And I was afraid that we might not even, when she'd come in, we would do Pilates with her. And she had a pretty decent Pilates routine. And she always said that she didn't have pain while she was doing the reformer work, doing the same movements, ironically, that she manifested pain in the screening. So very interesting. Michelle Gorga mentioned that the breathing bringing life energy to the cells. And there's no doubt that, all the power of breath from the physical, psychological, mental, emotional, and spiritual, from the foundations of nutrition to the body, were all being manifested in this case of breathing, right? It also managed the psychological aspect of it of spending more time in parasympathetic instead of sympathetic mode. Good. Good. So the idea is if the diaphragm contracts, the pelvic floor relax. So just remember that saying, right? Diaphragm contracts, pelvic floor relax. It's a relationship. And that might be the reason sometimes where we feel the people who have actually had decreased pelvic floor pain with Pilates could just be merely from the breathing aspect of our work. You get people breathing and it relaxes some of that hypertonicity of the pelvic floor and they start to feel better, right? If we can get that constant contracture out of the pelvic floor, are they going to be able to lubricate? Are they going to be able to do hygiene better? Are they going to have less pain with going to the bathroom and eventually being able to have intercourse without pain, right? So those are key things. All right. So what modifications would you possibly need to make to create a positive movement experience for Sally? Let's get that going. And then the anonymous attendee, you know what? She did not want to laugh. This is, there are times she couldn't hold it back because I like to tell jokes or say things that are funny or catch her off guard. But she really wanted to stay in that very melancholy state, right? And I'll tell you something else that I observed with her is sweating, right? So, just coming into the doctor's office or to her Pilates appointment, she would sweat profusely. Like I would lay a towel down on my table or the trapeze table to help absorb the, the sweat that she was going to sweat. And I always told her, just bring an extra set of clothes. Everybody sweats when they come to Pilates. It's okay. But she was very self-conscious of that. So it was like, sweat more. She was worried about her hands sweating, her feet sweating, and those things. So very interesting point you bring up. We use breathing, the studio, I love singing with exercise. And I had teamed up with Lauren Davidson, who some of you might know from Polestar courses and classes. And she teaches a lot of really cool things. And I had her working with Lauren, and Lauren was able to build a very strong rapport with her in the Pilates classes that she would do 2 or 3 times a week. And they were able to really make some great progress through taking the edge away, having some fun with it, and doing things like singing or harmonizing or laughing, those kind of things, which I think was getting her to the right person was very important as well. All right, let's see what you guys said. Yeah, so I think these were, for us, we needed to make and create a positive movement experience by restoring some movement, and we could manipulate load. And again, you sort of see they're all connected, right? So ideally, we're going to get to that coordination, and we use alignment and load to do that. What I would say is the most important one in the beginning was getting some mobility from the breath. And once we get the mobility from the breath, we can start moving into the load. Now, if you look at load in a different light, which I'm sure a lot of you are doing, is we modified load, right? So if we modify load, or we modify range of motion, or we modify repetition, that we can actually start getting more mobility. So again, my primary focus was to get the mobility back in that pelvic floor by using breath and the movement of other parts of the body to restore that mobility, so I could increase the load and the tolerance. Now remember, load does not just count for gravity or weight. It also is endurance and repetitions and tempo, are all other measurements that we use with load. And in Pilates, we manipulate load to be able to get successful movement experiences. So that's exactly what we did. Very, very good. All right, let's finish up with our program design, the last 5 minutes. So what exercises is your free for all? This is where you get a chance to do things. And here I would hope that I see some modifications, like how are you going to do some of the, I want you to imagine, what did Lauren and I do to get her where by 3 months, we had her able to sit through her class, she re-enrolled, and 6 months later, she graduated. She was never completely pain-free, and we never got her to the point of, being sexually active. But we were able to get her to a point of hygiene and confidence and doing her exercises every day and, significantly decrease in pain. So it took us about that long. So let's see what your, what you think would be some of the exercises and things you would prescribe for her in the Pilates environment. Let's see, I see, Irena, did I not answer your question, Irena? Would breathing in an inverted position help, or consider a correlation between the diaphragm and the pelvis? I don't know that we did it consciously, but I know that she was doing things like inverted V's, right? Lauren got her to the point where she could do planks and those kind of things, getting stronger without having pelvic floor pain. She was able to do things like parakeet on the trapeze table. So, these are all things after about 3 months of working with Lauren, where we were starting out with like the most basic of basics, unweighted, barely moving, giving her some successful awareness. Melinda mentioned the OOV. We've had the OOV since the beginning, and she did use the OOV. And that was also, we used the OOV for thoracic breathing, right? So if you lay on the OOV, the pelvic floor is suspended up, and with the thoracic spine down the way Daniel designed it. And one of the things we look at with pelvic floor health is that thoracic diaphragm breathing. So the OOV is fantastic for facilitating diaphragm breathing. So you could even do footwork on the OOV, like you lay on your back on the OOV in the normal OOV position, thoracic in the curve, and you're let the belly expand while she's doing her footwork. Let's see what you guys have. Okay, here we go. All right, so keep it coming with your ideas. Footwork on the reformer, breathing with TheraBand, pelvic clock, seated breathing, sitting on or over ball, reformer work, pelvic clock, dead bugs, bridging. Let's see. Yeah, seeing some nice things. Chest expansion, kneeling. You know what, one of the ones that we loved with her was the kneeling cat on the trapeze table. Leg circles, frog, yep, good. And, we took a little while before we started going into the pelvic floor with movement, like, doing stretching through the legs. At least not consciously. Like, I think that she was scared of feet and straps. It took about 3 weeks to get her to put feet in straps, just because the fear. So we really did keep our focus on, non-weight bearing through the pelvic floor, so no sitting exercises, and working on being able to create successful movement through the legs and through the chest, even though what you realize is if you're moving the legs, you're then getting into the pelvis. And it was after about a month that we started going into our pelvic clocks, going into some bridging and some of these other movements now that she could do without over recruiting or resisting herself. So the breathing was by far the biggest one. Well, we are out of time. I am going to open it up just a little bit for some questions. You guys' ideas are always fantastic. I learned a lot from you. Somebody put book openings. And book openings was a super exercise because you could do that at home. So thank you for thinking of that. All right, I'm open for some Q&A. We're done with the case. Again, you know, every case is different. Every person is an individual. I think there were probably, you know, it was so complex, but I wanted you to realize is that going through and all the doctors that couldn't figure things out, you know, all the King's men couldn't put her back together again. And our focus on something as simple as breath, a little bit of regular meditation throughout her day, and then Pilates, getting her to where she started having successful movement experiences, being very patient. She was able to really get to a point that she could finish her college. That was a big feather in her hat. Her parents and her sisters had commented on how much happier she was. She commented how much happier she was, and you know, now she can address some of her other challenges that she had. I see Olga bringing up the idea of endocrinologist, and again, you know, think of you know, being even in sympathetic mode all the time, and you know what causes sweats. You know, maybe she was also sort of that what do you got, post-menarche kind of thing syndrome, where she was for so long she wasn't having a normal period, so her body could be reacting like hot sweats or those kind of things that she had. So there were a lot of other aspects to that. Jennifer, would you refer her on to another PT or pelvic floor specialist since she was not able to be sexually active? She was working with Pam, and Pam was able to do some internal work that got her to where she could tolerate a tampon. And Pam's idea was just that she was going to continually progress. And when she was ready, she would know when she was ready. And so by the time I discharged her, she was able to use a tampon successfully. So, but still not sexually. And I think that, you know, if she was willing to go back to counseling, that would be, you know, if she was serious with this boy, is that the two of them would go to, you know, a therapist for relation counseling and sex therapy. I think that she would need to go through some counseling for that as well. Let's see, Sylvia Rodriguez. Can you suggest a free app to recommend for meditations? Yes, I can. I'll tell you the one that I use. It's called Insight Timer. Insight Timer. I'll type that into the group chat. There's a lot of them. That one has a lot of free stuff. So that's the one I give to my patients and has a lot of options to use. So let's see. Anonymous attendee, is she better? Is Pilates helping? So yeah, that's what I mentioned. About 3 months later, she was able to go back to school, enroll in the fall, graduated in December, got her degree or diploma. She walked. She did have some little tricks of things that she could use to make the seat a little more comfortable for her. She wasn't pain-free, but she was much happier, and she was able to finish and graduate school, which was her primary thing. We hit 2 of her 3 goals. And I think a lot of you, you know, like it takes a village to deal with a case like this. I mean, there are family issues as far as the stress that she perceived. There was a relationship issue of a boyfriend who actually was very, very patient with her and really loved her. Very cute couple, but was patient to wait until she was ready to have sex. Even though they slept together and they lived together in an apartment, they were not sexually active because of her condition. Very affectionate. So that wasn't the issue either. I mentioned I was going to tell you a quick story. I had a client that was 21, already married, and she was sent to me for fibromyalgia, not a pelvic floor issue, but just fibromyalgia. And, you know, we had tried everything, Pilates, gyrotonic, meditation, all these things to try to get her pain down. Nothing was working. We'd get a temporary relief. And so Alistair Greetham was training me on doing some hypnosis. And so I figured I would try using some of the hypnosis with her. And as I was going through the hypnosis, took her down to a couple states, and, you know, you learn to ask the questions like, you know, what's the color of the pain? What's the texture of the pain? What's the temperature of the pain? By the time I got to what's the purpose of the pain, it was like she turned into a monster. It was like, I forget, Exorcist, right? My name, you know, it was like really scary. Like I had my hair on the end of my arms. And she told me that that she was talking as third person as purpose. And the purpose was to remind her that that children were the cause of divorce. And she continued to tell me that when she was 16, her mother told her that if she had not spent so much time with the children, she would not have lost her marriage. So when you think about it, the husband and she were madly in love with each other. They'd been married for a couple of years. They pretended that they wanted to have kids. He certainly wanted to have kids, but she said that she had so much pain that she didn't want to get pregnant right now while she was having so much pain. But when we got into the hypnosis, the pain was there to remind her that children were the cause of divorce. So we sent her immediately to a family counselor to deal with it. But then I got letters, years later, that she no longer had fibromyalgia. She was a yoga teacher, and they still didn't have any kids, but that she no longer had pain. So she apparently dealt with whatever she was dealing with. Totally out of my league. But just the idea that, our psyche, our beliefs, things we heard, they can affect us so much, so much. Okay, everybody, thank you for participating today. I'm working on what I'm going to do next week. You've given me a huge, long list of things that we could look at. So I'm going to try to come up with something exciting. We'll be sending it out on Monday. I do promise it'll be fun. And, we'll see you then. And you'll get an invitation on Monday for the following Thursday. So have a great weekend. Be safe. I did want to mention to you, those of you that are members of the PMA, now would be a very good time to express things that you want and things that you want to see in sort of the restructuring and revamping of the PMA. It's going through a very difficult time, but it is going to go through a remodeling, sort of a revision if it survives all the change. But I think that as members, it's supposed to be a membership organization, and as members, we should be giving feedback. I also want to give a shout out to Future and hope that we can stay in a non-divisive state in the United States with our new president, and that we can work hard at listening to each other and making sure that we get rid of the anger, bring it up a couple notches. So keep that in your prayers and your meditations. We'll see you next week.